Okay, hello everyone. Assalamu alaikum. Today we'd like to talk about the safety and contraindications for thrombolysis. So as you've heard from the other lectures, so first of all, we're excluding a bleed and confirming the diagnosis, both clinically and from imaging, like CT or MRI, then deciding the severity of stroke, and then determining any contraindications. And of course, later on, we give the treatment of thrombolysis. All right, so why IV thrombolysis? So IV thrombolysis treatment increases the chance of favorable outcome at 90 days. So regardless of the index or the score that you look at, so whether it's NIH score, Bartle index, modified Rankin, etc., you see a favorable outcome at 90 days. And you can see it's significant. This is what we tell the patient. So this is out of 100 patients treated, we tell them about 32 will benefit, and just about 3 might be harmed. So the safety profile of Acute. So they looked at from PCAS-3 trial, the mortality by time interval. So they saw there's no increase in risk of 90-day mortality in patients treated with TPA within 3 hours of symptom onset compared to placebo. You can see in this section here, 0.9 versus 3.2. Although there is a risk of, there is a significant increase in the rate of symptomatic intracranial hemorrhage for patients treated up to 4.5 hours after symptom onset with TPA compared to placebo, the overall risk of ICH is low and mortality rate is low and similar to both patients. You can see 90 days, the mortality 3.8 versus 4.5, so it's less than the placebo. The evidence for benefit for TPA was that they, regardless of the treatment delay, age, or baseline NIH score. If you look at the treatment delay, you can see less than 3 hours, it's good outcome, 3 to 4.5, again, and more than 4.5, it crosses the midline, but still towards more favorable outcome. You can see it's interesting, regardless of the age, so less than 80, more than 80, still it's towards the more benefit. And also regardless of the baseline NIH score, so regardless of the score, the stroke was mild, moderate, or severe, you can see universally it was better outcome. The TPA effect are time dependent. You can see the numbers needed to treat. If you treat them the earlier the possible, the earlier the better, of course. You can see between 0 to 1.5 hours, the numbers needed to treat were 4.5. If it was treated between 1.5 to 3 hours, numbers needed to treat doubles, goes up to 9. And beyond that, 3 to 4.5, the numbers needed to treat is about 14. This is the same representation again. The earlier we treat, the greater the benefit for the patients. You can see less than 90 minutes, numbers needed to treat, 4 to 5. 90 minutes to 3 hours, the number needed to treat is 9. And again, between 3 and 4.5 hours, the numbers needed to treat goes up to 14. All right, so this is just a representation of the Sedan score. So it can predict the hemorrhage because it's always a concern. So Sedan stands for sugar, early infarct, dense or hyperdense MCA, age, and NIH score. So the higher their blood glucose, they're given a score. The early infarct sign on admission CT scan, whether it's present or not. Dense or hyperdense cerebral artery on admission CT, again, yes or no. Age, less than 75, more than 75. NIH score on admission, given points. So if they have the higher the score, the more likely the bleed. So what else determines the benefit? The clot location. Okay, so this is very important. The more proximal, it is well known, the more proximal the occlusion is, the less likely it will respond to IV thrombolysis and they need mechanical thrombectomy. This is true for ICA, say around 4.4%. Same for basilar artery. And the more distal you go, you see it goes up to 30 or even 40%. In another systematic review and meta-analysis published in Stroke 2016 by Pierre et al., they looked at partial or complete recanalization. You can see in the basilar, around 13%, same for the ICA. Then it went up to an M1, about 35%. For M2, M3, it goes up to 52%. Interesting. For complete recanalization, similar to the other study, around 4% for ICA and basilar artery. For M1 occlusion, about 21%, and beyond that, M2, M3 is 38%. Another factor is the clot length that determines the response to IV thrombolysis. You can see the longer the clot is, the less likelihood that it would recanalize. And usually from studies, if it's more than 8 millimeters, it is less likely to respond to treatment. Another factor is the clot composition. So the clot or the thrombus composition also affects the response to IV thrombolysis. So in one study, they looked at thrombus composition and the efficacy of thrombolysis and thrombectomy in acute ischemic stroke. This was by Rikios et al. It was published in Stroke 2021. So the clot is either fibrin-rich or RBC-rich. So which component is more predominant? The fibrin-rich clot was more resistant to thrombolysis because it was less permeable. There was less penetration for TPA because they had smaller pores versus the RBC-rich clot. It was also more difficult to retrieve by mechanical thrombectomy, the fibrin-rich clot, because it was more dense and compact compared to the RBC-rich, which was easier to retrieve, but it fragmented more easily. So now we come to the main talk with the contraindications. This is a very nice mnemonic. It says no TPA. So N for neoplasm, so the brain. The heart for endocarditis, either suspected or known. Then the T, 3 months, 3 weeks. So within 3 months, no head trauma, neurosurgery, or ischemic stroke. Within 3 weeks, GI bleed, GI malignancy. P for low platelets, less than 100. A for active bleeding, subarachnoid hemorrhage, ICH, aortic dissection. A for AVMs, aneurysms, and anticoagulation. Now I'll just mention with some details the 2019 updates to the guidelines, American Heart Association, American Stroke Guideline for early management of patients with acute ischemic stroke. So they divided it into green, yellow, orange, and red. So strong recommendation, less stronger recommendation, and later on harmful or not recommended. So in the green zone, so within 3 hours, IV alteplase 0.9 milligrams per kg, maximum dose of 90 milligrams over 60 minutes with initial 10% dose was given as a bolus over 1 minute, is recommended for selected patients who may be treated within 3 hours of ischemic stroke symptoms. Then within 3 hours, with regards to age, for otherwise medically eligible patients more than 18 years of age, it is recommended within 3 hours. Within 3 hours, with regards to severe stroke, for severe strokes, IV alteplase is indicated within 3 hours from stroke onset. So within 3 hours with mild disabling stroke, for otherwise eligible patients with mild but disabling stroke, IV alteplase is recommended for patients who can be treated within 3 hours. For 3 to 4.5 hours, IV alteplase is also recommended for selected patients who can be treated within 3 and 4.5 hours of ischemic stroke symptom onset or patients last known well. For 3 to 4.5 hours, with regards to age, IV alteplase treated in the 3 to 4.5 time window is recommended for those patients less than 80 years of age, without a history of both diabetes mellitus or prior stroke, NIH score of less than 25, not taking any oral anticoagulants, and without imaging evidence of ischemic injury involving more than 1/3 of the MCA territory. For urgency, treatment should be initiated as quickly as possible within the above listed timeframes, because time of treatment is strongly associated with the outcome, as I mentioned before. For blood pressure, IV alteplase is recommended in patients with blood pressure less than 185 by 110. Okay. For blood glucose, IV alteplase is recommended in otherwise eligible patients with initial glucose level of more than 50 milligrams per deciliter. For the CT scan, IV alteplase administration is recommended in the setting of early ischemic changes on the non-contrast CT of mild to moderate extent, with otherwise other than frank hypodensity. Prior antiplatelets, so IV alteplase in spite of patient being on antiplatelets, monotherapy, or even in combination, or even in patients taking combination, say for example, aspirin and clopidogrel, So the benefit of alteplase overweighs the possible increased risk of bleeding. What about patients in end-stage renal disease? So for those, IV alteplase is also recommended. However, if those with elevated APTT may have elevated risk of hemorrhagic complications. Then in the yellow or orange, so this is maybe a much less stronger recommendation. So between 3 to 4.5 hours, with regards to age, for patients more than 8 years of age presenting with 3 to 4.5 hour window, IV alteplase is safe and can be as effective as in younger patients. In the same period, 3 to 4.5 with diabetes mellitus and prior stroke. So with prior stroke and presenting within 3 to 4.5 hour window, IV alteplase may be as effective as treatment in the 0 to 3 hour window and may be a reasonable option. The 3 and 4.5 hours with severe stroke. So the benefit of IV alteplase between 3 to 4.5 hours from symptom onset for patients with very severe stroke symptom, that is NIH score more than 25, is uncertain. 3 to 4.5 hours mild disabling stroke. For those eligible patients with mild disabling stroke, IV alteplase may be reasonable for patients who can be treated within 3 to 4.5 hours. What about wake up and unknown time of onset? So it may be administered within 4.5 hours of stroke symptom recognition, may be beneficial, or in those with stroke symptoms or have unclear time onset of more than 4.5 hours from last known well, or at a baseline state who have DWI on the MRI lesion smaller than 1/3 of the MCA and have no visible signal change on the flare, so they have mismatch. What about pre-existing stroke? So it does not seem to be independently increase the risk of symptomatic intracerebral hemorrhage after IV alteplase, but it may be associated with less neurological improvement and higher mortality. So it may be, so IV alteplase for acute stroke with pre-existing disability, MRS more than 2, may be reasonable. But of course, each patient is evaluated independently. Early improvement. So IV alteplase treatment is reasonable for patients who present with moderate to severe ischemic stroke and demonstrate early improvement but remain moderately impaired and potentially disabled by the judgment of the examiner. What about seizures? So seizures at the onset. So IV alteplase is reasonable in a patient with seizure at the time of onset of acute stroke if evidence suggests that residual impairment are secondary to stroke and not a post-ictal phenomenon. With regards to blood glucose, treatment with IV alteplase in patients with acute ischemic stroke who present with initial glucose level of less than 50 or more than 400 that are subsequently normalized and who are otherwise eligible may be reasonable. With regards to coagulopathy, IV alteplase may be reasonable in patients who have a history of warfarin use, an INR of less than 1.7, or a PT of less than 15 seconds. What about dural puncture? So IV alteplase may be considered for patients who present with acute ischemic stroke, even instances when they may have undergone a lumbar puncture in the last 7 days. Arterial puncture, the safety efficacy of administering IV alteplase in acute stroke patients who have had an arterial puncture for non-compressible blood vessel in the preceding 7 days are still uncertain. Recent major trauma in acute ischemic stroke with recent major trauma that's within 14 days, not involving the head, IV alteplase may be carefully considered with the risks of bleeding from injuries related to the trauma weighed against the severity and potential disability from the ischemic stroke. What about recent major surgery? So the use of IV alteplase in carefully selected patients presenting with acute ischemic stroke who have undergone a major surgery in the preceding 14 days may be considered, but again, the potential increased risk of surgical site hemorrhage would be weighed against the anticipated benefits of reduced stroke-related neurologic deficits. What about GI and genitourinary bleeding? So in the reported literature, the details a low bleeding risk with IV alteplase administration in the setting of past GI and genitourinary bleeding, administration of IV alteplase in these patient population may be reasonable. However, it's important to note that administration within 21 days of GI bleed event is not recommended and contraindicated. For menstruation, so IV alteplase probably indicated women who are menstruating who present with acute ischemic stroke and do not have a history of menorrhagia. When history of recent or active vaginal bleeding causing clinically significant anemia, then emergency consultation with the gynecologist is probably indicated and a decision about IV alteplase is made. What about extracranial cervical dissection? IV alteplase in acute ischemic stroke known or suspected to be associated with extracranial cervical arterial dissection is reasonably safe within 4.5 hours and probably recommended. For the intracranial arterial dissection, the IV alteplase usefulness and hemorrhagic risk known or suspected to be associated with intracranial arterial dissection remain unknown and uncertain and not well established. For the unruptured intracranial aneurysms, for patients presenting with acute ischemic stroke who are known to harbor a small or moderate size that is less than 10 millimeters, unruptured, unsecured intracranial aneurysm, administration of IV alteplase is reasonable and probably recommended. The usefulness and risk of IV alteplase in patients with acute ischemic stroke who harbor unruptured or unsecured intracranial aneurysm are not well established. The usefulness and risk of IV alteplase in patients with acute ischemic stroke who harbor a giant unruptured and unsecured intracranial aneurysm are not well established. For intracranial vascular malformations, for patients presenting with acute ischemic stroke who are known to harbor an unruptured and untreated intracranial vascular malformations, the usefulness and risk of admission of IV alteplase is not well established. Because of the increased risk of ICH in this population, IV alteplase may be considered in patients with stroke with severe neurological deficit and high likelihood of morbidity and mortality. For cerebral microbleeds and otherwise eligible patients who have previously had a small number, that is 1 to 10, of cerebral microbleeds demonstrated on MRI, administration of IV alteplase is reasonable. In otherwise eligible patients who have previously had a high burden of cerebral microbleeds, that's more than 10, demonstrated on MRI, treatment with IV alteplase may be associated with increased risk of symptomatic intracerebral hemorrhage, and the benefit of treatment are uncertain. Treatment may be reasonable if there is potential of sustainable benefit. Concomitant use of IV glycoprotein 2B3A inhibitors with IV alteplase is not well established. For extraaxial intracranial neoplasms, IV alteplase treatment is probably recommended for patients with acute ischemic stroke who harbor an extraaxial intracranial neoplasm. What about MI? Another important topic is MI. So for acute MI, for patients presenting with concurrent stroke and acute MI, treatment with alteplase at the dose appropriate for cerebral ischemia followed by percutaneous coronary angioplasty and stenting is indicated. For recent MI, so patient presenting with acute ischemic stroke and the history of recent MI in the past 3 months, treating ischemic stroke with IV alteplase is reasonable in the recent MI. If the recent MI was non-STEMI, that's class of recommendation 2A, the same for if it's STEMI involving the right or inferior myocardium, but class of recommendation 2B if it was again STEMI, still recommended for the STEMI involving the left anterior myocardium. For acute pericarditis, for patient with major acute ischemic stroke, likely to produce severe disability and acute pericarditis, treatment with IV alteplase may be reasonable. For patient presenting with moderate acute ischemic stroke, likely to produce mild disability and acute pericarditis, treatment IV alteplase is uncertain net benefit. For those with left atrial or ventricular thrombus, presenting with acute ischemic stroke, likely to produce disability and known left atrial or ventricular thrombus, treatment IV alteplase may be reasonable. For other cardiac diseases such as myxoma or papillary fibroblastoma, it's also may be reasonable. For procedural stroke, so IV alteplase is reasonable for treatment of acute ischemic stroke, complication of cardiac or cerebral angiographic procedures, depending on the usual eligibility criteria. What about malignancy? For systemic malignancy, the systemic, For systemic malignancy, the safety and efficacy of IV alteplase in patients with current malignancy are not well established. What about pregnancy? IV alteplase administration may be considered in pregnancy when the anticipated benefits of treating moderate or severe stroke outweigh the anticipated increased risk of uterine bleeding. The safety and efficacy of IV alteplase in the early postpartum period, that is less than 14 days after delivery, have not been well established. Ophthalmological conditions are also important. The use of IV alteplase in patients presenting with acute ischemic stroke who have a history of diabetic hemorrhagic retinopathy or other hemorrhagic ophthalmic condition is reasonable to recommend, but the potential increased risk of visual loss should be weighed against the anticipated benefits of reduced stroke-related deficits. For sickle cell disease, IV alteplase for those with acute ischemic stroke and sickle cell can be beneficial. It's important for our region. Hyperdense sign, IV alteplase can be beneficial, so it's not contraindicated as used to be thought before. For illicit drug use, it's again can be used. For stroke mimics, again, the risk of symptomatic intracranial hemorrhage in the stroke mimic population is quite low, so starting IV alteplase is probably recommended in preference over delaying treatment to pursue additional diagnostic studies. Finally, we come to the contraindications, as you can see in the red zone. So between 0 to 3 hours window in mild to non-disabling stroke. So for otherwise eligible patients with mild non-disabling stroke, and I score 0 to 5, IV alteplase is not recommended for patients who could be treated within 3 hours of ischemic stroke symptom onset or patients last known well or at a baseline state. For 3 to 4.5 hours window with mild non-disabling stroke, IV alteplase is not recommended for patients who could be treated within this time period. With regards to CT, there remains insufficient evidence to identify a threshold of hypoattenuation severity or extent that affects the treatment response to alteplase. However, administering IV alteplase in patients whose CT brain imaging exhibits extensive region or clear hypoattenuation is not recommended. These patients have a poor prognosis despite IV alteplase, and severe hypoattenuation defines an obvious hypodensity, represents a reversible injury. So there's no point of treating them and could be harmful. Intracerebral hemorrhage, IV alteplase should not be administered to patients whose CT reveals acute intracerebral hemorrhage. For ischemic stroke within the past 3 months, so IV alteplase in patient presenting with a stroke who had a prior ischemic stroke within 3 months may be harmful. Severe head injury within 3 months, again, is contraindicated. For acute head trauma, given the possibility of bleeding complication from underlying severe head trauma, IV alteplase administered in post-traumatic infarction that occurs during the acute in-hospital phase. It should not be administered. For intracranial or intraspinal surgery within 3 months for patient with acute ischemic stroke and a history of intracranial or spinal surgery within 3 months is potentially harmful. For history of intracranial hemorrhage, IV alteplase administration with those with ICH potentially harmful. For subarachnoid hemorrhage, IV alteplase presenting with symptoms and signs most concerned with subarachnoid hemorrhage may be harmful and it's contraindicated. For GI malignancy or GI bleed within 21 days, so within 21 days, their stroke event should not be considered high risk. For GI malignancy or GI bleed within 21 days, should be considered high risk, and IV alteplase administration is potentially harmful. For coagulopathy, the safety of and efficacy of IV alteplase in acute ischemic stroke with platelets of less than 100,000, an INR of more than 1.7, and an APTT of more than 40 seconds or PT more than 15 seconds are unknown, and IV alteplase should not be administered. What about low molecular weight heparin? Again, should not be administered if they have received the full treatment dose of low molecular weight heparin within the previous 24 hours. If they have received thrombin inhibitors or factor 10 inhibitors, this is now a very important topic. So the use of IV alteplase in patients taking direct thrombin inhibitor or direct factor 10A inhibitors has not been firmly established, but may be harmful. So alteplase could be considered when patients appropriately selected and appropriate laboratory tests such as APTT, INR, clotting time, thrombin time, or direct factor 10A activity assay are normal, or when the patient has not taken the dose of their anticoagulant for more than 48 hours and renal function is normal. Concomitant abciximab should not be administered when concurrently with IV alteplase. Concomitant IV aspirin should not be given within 90 minutes after IV alteplase. For infective endocarditis, so patient with ischemic stroke and infective endocarditis, treatment with IV alteplase should not be administered because of the increased risk of intracranial hemorrhage. With regards to aortic arch dissection, IV alteplase potentially harmful and should not be administered. With regards to intraaxial intracranial neoplasm, IV alteplase is potentially harmful, should not be administered. Okay, thank you.